Okay, well, welcome back, everybody. This week we're going to be discussing chapter 47 in your Egan's book about the physiology of ventilatory support. So, this chapter covers a couple new learning objectives, but for the most part, we're going to be discussing topics that we've already kind of covered in cardiopulmonary physiology and in chapter 45 and 46 of your Egan's book this semester. So, just a kind of a refresher when it comes to pressures and pressure gradients. The pressure gradient, as you guys already know, is what is going to cause that gas flow to occur. So, you need to have that pressure gradient has to exist in order for gas to flow from the atmosphere into our lungs. Okay. So there's a couple different pulmonary pressures that your book kind of talks about. I feel like it's easier to discuss this when you're kind of get the visual. So during normal physiologic breathing, um, kind of at the end of expiration, your interpleural pressures are going to be just kind of slightly negative. Um, so that slight negative pressure helps to keep these alveoli pulled in that open position. Um, during inspiration, that's when your diaphragm contracts and it moves downward into your abdominal cavity. And that causes more negative pressure to be placed on the outside of those alveoli. And those alveoli get pulled more open, creating a negative pressure or pressure deficit inside those alveoli. So the air from the atmosphere wants to flow into the lungs. Okay, the air is going to continue to flow into the lungs until you get to kind of this neutral pressure where the pressure in the atmosphere is kind of equal to the pressure in those alveoli so that gas flow stops. Then when the diaphragm relaxes, it's going to move back up into the thoracic cavity, putting this positive pressure on the outside of those alveoli, making those alveoli want to recoil or go back to their neutral state and the air to flow back out into the atmosphere. Okay, that's going to continue to happen until you kind of get that neutral state again with the pressure inside the alveoli matching kind of the pressure on the outside of the alveoli or in the atmosphere. And, you kind of don't no longer have that pressure gradient. Okay, so that's kind of how the philosophy of kind of how this happens or how this works physiologically. Then moving on, your book talks about negative pressure ventilation and positive pressure ventilation. So how can mechanical ventilation assist with this process? So negative pressure ventilation, the patient is sitting inside like some sort of a chamber. It's a sealed chamber so that the machine can pull air out from around the chest wall, creating this negative space here, making the chest wall want to open up. Okay. And the patient then to have um, negative pressure in the chest and the air from the atmosphere to flow into the lungs. Okay. So it mimics more of physiological breathing, meaning then that it's going to have less kind of physiological side effects. When compared to like positive pressure ventilation, okay? Because this is more natural, more of kind of the natural way that we breathe. Our tissues are going to respond kind of the same way as spontaneous breathing, and there's going to be less side effects. One of the positives for having or a pro of using non-invasive excuse me, I'm going to do that a million times. A positive or a pro of using negative pressure ventilation is that you don't need a patient interface. So I don't need the patient to be intubated in order to use negative pressure ventilation because I'm not applying the pressure directly to the airway. I'm applying the negative pressure to the chest wall. So my patient isn't going to be intubated. So that means that they're not going to need um, they're not going to need a lot of sedation, um, but they will need to be on supplemental oxygen if the patient has oxygen demands. Okay, so this negative pressure machine here isn't going to be supplying any oxygen to my patient. If I want my patient on oxygen, they need to be on like a low flow or high flow device to help with their oxygen needs. Okay, but they don't need to be intubated, so all the complications of intubation go away. So, some of the negatives of using negative pressure ventilation, though, are the fact that the patient has to stay in this kind of sealed chamber. So assessing our patients is going to be a lot harder. It's going to be difficult to listen to my patient's lung sounds or look at my patient's skin, do any type of assessments at all while they're in this chamber. It's also kind of limiting for the patient. So even though they're not going to be sedated, it's not like this patient's going to be up and moving around like they can on the positive pressure ventilator. So there are some positives, some negatives of using negative pressure ventilation. Your positive pressure ventilation, which is what we've been talking about, this is using a machine to increase that kind of atmospheric pressure, right? So it's adding pressure here at the airway opening. So this becomes more positive. So then this pressure gradient is created by adding pressure here rather than taking pressure away down here. So that pressure is going to flow from areas of high pressure to areas of low pressure and then end up in the lungs. Okay, and again, this is not the way we physiologically breathe. So that added positive pressure to the lung tissue does lend itself or can cause injury. Right. I did kind of like this picture when it's just to kind of bring these kind of concepts together with the pressure gradients, volumes, and airflow and airway resistance. So this picture here shows you that, again, air is going to enter the lungs from an area of high pressure to an area of low pressure. I can either artificially make the pressure down here low by using a negative pressure ventilator to pull those lungs open from the outside, or I can artificially make this pressure gradient by adding pressure up here, which is most commonly what we do. Okay, so when this pressure gradient is created, air is going to flow into the lungs, right? Or out of the lungs, depending on which area is high, which area is low. We're talking about exhalation versus inspiration. So air is going to flow into the lungs here. Things that are going to affect how much volume actually makes it into the lungs are things like airway resistance. So airway resistance is what's going to affect that flow of gas. So things like the diameter of these tubes, any type of obstruction, any type of viscosity of the gas that's flowing in there. So simply put, airway resistance, type this out, airway resistance is going to be equal to the change in pressure divided by the flow rate. Okay. That's my airway resistance, and I'm going to move this box. Oopsies. Doesn't want to let me grab this here. Hold on for a second. I want to do that. Oops. I lost it all together. Shoot. Sorry. Okay. I'm going to try this again. Raw is equal to my change in pressure divided by my flow rate. Okay. So if you wanted to rearrange that equation to solve for pressure, okay, I would just have to take, excuse me, raw times my flow rate equals my change in pressure. Okay. All right. So that's me just rearranging so that the change in pressure is on its own on one side. Okay. That's just simple math. Don't get too wound up about it. just know that this is the rearranged equation for change in pressure. All right, so down here, let's discuss compliance now. So the other thing that's going to affect the volume getting in is your compliance. So how stretchy these alveoli are. If they're too stretchy, that means volume can easily get into this alveoli, but then I'm going to lose my recoil, that elastic recoil that helps get the volume back out. That's what you see in like patients with emphysema. So compliance is going to always equal, is going to be equal to the change in volume divided by change in pressure. Okay, these equations, you guys should know these now. So if I want to rearrange this equation for change in pressure, so change in pressure equals volume divided by compliance. Okay. All right. So what I'm trying to demonstrate with this math then is that this pressure gradient, in order for volume to enter my lungs, this pressure gradient has to equal the airway resistance times the flow rate and the volume divided by the compliance. You're not going to do this math, but it's just kind of important that you understand that the change in pressure or pressure gradient, in order to produce volume for the patient, that has to exceed the volume divided by the compliance plus the resistance, airway resistance, times the flow rate. All right. Some other things to kind of understand about mechanical ventilation is minute ventilation. So we've discussed minute ventilation a bunch. Minute ventilation is your tidal volumes times your frequency or your respiratory rate. So this minute ventilation is what's going to help us remove the CO2 from our lungs. So when you have that hypercapnic respiratory failure, your CO2 is going to be high, which is going to cause your pH to be low. Okay. So, you can operate under the assumption that if I increase my minute ventilation, that is going to improve my elimination of CO2 from my body, and that pH then will become normalized. Okay, so I can accomplish this by either increasing the tidal volume or increasing the respiratory rate for my patient, or I can be doing both. That's going to really depend on patient situations. So your book mentions that a normal tidal volume, your tidal volume for your patients, should equal about 4 to 8 milliliters per kilogram. Okay. And that's ideal body weight. Okay. So when we get to lab this week, we're going to be discussing how to calculate out ideal body weight. Okay, that's kind of an important calculation for you guys to know how to do. And I'm going to teach you probably, I think, the easiest of the calculations to do for that. So when we're setting up our ventilators for our patients, we want to first make sure that the volume that we're picking falls within this range. So your book mentions 4 to 8 milliliters per kilogram. I would say in most patients, you're going to be trying to get between the 6 to 8 milliliters per kilogram range. That 4 to 6 milliliter per kilogram, the low range of this range, the low end of that range is usually for like certain specific types of patients that need low tidal volumes. But for most all of our patients, we're going to be doing this 6 to 8 milliliters per kilogram, which is probably what you see in clinicals a lot. Okay, so you want to make sure you're setting your tidal volume based on this. Okay, your respiratory rate then, the other part of your minute ventilation, is going to be set based on like normal respiratory rates. So typically we like to see a respiratory rate initially to be within the 10 to 16 breaths per minute range. Okay, that's typically what we want to see. Okay, so this is for MBRC. Pershing mentions this. Your Pershing book mentions this. Your Egan's book talks about trying to keep your respiratory rate from 12 to 20. And I would say that that's also a fair range for most of your patients are going to be within that 12 to 20 range for continued ventilation. It's the big concept that with this is respiratory rates greater than 20 breaths per minute are going to increase your chances of gas trapping. Okay, so that's something you need to be concerned about. Okay, so then you can kind of see how I'm gonna kind of put my tidal volume somewhere within the 68 milliliters per kilogram range. I'm gonna get ABGs back. My respiratory rate's gonna be somewhere initially between that 10 to 16 range. And then when I get my ABG results back, I'm going to make adjustments either to my tidal volume or to my respiratory rate to best suit my patient's needs. And again, this makes more sense when you actually get to kind of practice it on a patient. But, I might be at 7 milliliters per kilogram over here. So I'm right in the middle of the range. And then I might be at 16 breaths per minute over here. So you might increase to 18, increase to 20, but once I get to 20, I might go, oh, I don't want to go any higher than 20. So I might go back over here and increase my tidal volume again. So it's, again, very, very specific to individual patient situations. We will be practicing that. Excuse me. All right. So remember too with ventilation, the difference between alveolar ventilation and minute ventilation. So alveolar ventilation is the ventilation that actually is participating in gas exchange. So the better your alveolar ventilation, the more CO2 you're going to be removing from the body. Okay. So what's going to affect alveolar ventilation is rapid shallow breathing. So this part of your book is really talking about the negative impact from rapid shallow breathing. Okay. So my minute ventilation can look good, right? If I'm breathing really fast, that's going to be part of the equation for my minute ventilation, but my tidal volumes could be really, really low. So, just using really super simple math here. Let's say I'm breathing at a respiratory rate of 10 with a tidal volume of 500. Okay. So that gives me a 5 liter per minute VE. Okay. But my patient could have an incident where they're breathing at a rate of 20 times a tidal volume of 250, which also gives me a 5 liter per minute VE. This patient here, with the rate of 10 and a 500 tidal volume, could have a normal PCO2. But this patient down here with the respiratory rate of 20 and that very low tidal volume could be having a very high PaCO2 because most of this volume never even takes part in gas exchange because that volume is getting wasted in that anatomic dead space. Everybody hopefully everybody's kind of remembering that or understanding that. So just to recap again, it's your alveolar ventilation that participates in gas exchange. So removes the CO2 from our body. So thinking just strictly about minute ventilation, this patient and this patient A, I'm going to put an A here, patient A and patient B, both have the same minute ventilation of 5 liters per minute. Patient A probably has a normal PaCO2. right? PaCO2 is normal because VT exceeds dead space, okay, VD. In patient B, this patient would have a high PaCO2 because VT is, let's say, equals VD or is close. So most of the gas in patient B isn't participating in gas exchange. All right. So moving on to ventilation perfusion ratio. So spontaneous breathing is going to have that gas distribution to the dependent parts of the lungs. So when we put patients on positive pressure ventilation, tidal volume is going to be delivered to kind of non-dependent parts of your lungs. So this is going to be, there's a figure in your book on 47.5 that just kind of talks about how sometimes your lungs are going to get a different distribution of ventilation to perfusion. So so the blood flow is going to be greatest in those dependent regions. The ventilation is going to end up in those non-dependent regions, and then you're going to have that worsening VQ mismatch. Okay, so if blood and ventilation are coming in good close contact with each other, you're going to have a widening of that A to A gradient, meaning, okay, so this is my big A here. My P big A is what's inside the alveoli. And my P little a is what gets into the capillaries. Okay. So the gradient is the difference between these two. So if my patient has getting ventilation in because of positive pressure ventilation, but perfusion isn't happening here, what's getting into the alveoli and then what's diffusing across to the capillaries, not as much is going to diffuse across to the capillaries. So your AA gradient increases, meaning that more oxygen stays in here and doesn't get into here because these two aren't coming into contact with each other. Okay, so your alveolar and arterial carbon dioxide. So normally your alveolar carbon dioxide tension, so that is, excuse me, let me make the little drawer thing back out again. I guess I'm gonna draw this capillary with the red. And then my little alveoli here. Okay. So let's say my CO2 in here is my PaCO2. Oops. That's this guy. Then blue. And then your P little a CO2 is represents the red area or the pink area. So normally that should be about 40. So under normal circumstances, the CO2 is going to move out of the blood and into the alveoli. Okay. But when you have a decrease in that alveolar ventilation, or when you have an increase in the production of CO2 in the body, the amount of CO2 that's in the blood here is going to increase. Okay. So that mechanical ventilation can increase that minute volume, and that alveolar ventilation to reduce those things. But if you have an increase in that dead space to tidal volume ratio, then you're going to have, so actually, let me say that a different way. So let's talk about what can kind of affect this. If you have like a blood clot right here, okay, and even though alveolar ventilation is staying the same, this blood isn't coming in contact with my alveoli, so the CO2 can't pass into this alveoli space. Okay, so when that happens, my PaCO2 is going to increase. Okay. And because I have adequate ventilation, an increase in minute ventilation isn't going to help this because I have that VQ mismatch here because there's no perfusion happening to this. So your PaCO2 is going to increase, and that's either due to an increase in dead space ventilation, or that's commonly seen in like PEs. So let me just go through that again. Okay. So in the lungs, your CO2 comes in from the pulmonary capillaries. It is supposed to then diffuse across that AC membrane into the alveoli and be exhaled. And we usually measure that as your PET CO2. Okay, that's what the patient exhales. Okay, that should match your PaCO2 or be close to it. That's what happens normally. But if you're using excessive amounts of PEEP, if your patient has a pulmonary embolism, or if your patient's alveoli are over distended because of emphysema, that is going to result in this alveoli here pushing on this capillary, blocking this blood flow. So now I have no blood flow here. So now, because the CO2 is not coming in to get deposited, it stays in the blood. My TETCO2 is going to go down. My P big A CO2 is going to go down because the blood, it didn't diffuse across. My PaCO2, little a CO2, is going to increase because that CO2 had nowhere to go. And I'm going to have a big difference between my end tidal CO2, my arterial CO2. And that usually gives me, as a respiratory therapist, an indication that my patient either has too much PEEP, pulmonary embolism, or some sort of overdistension that's causing a perfusion issue in the lungs. Excuse me. Okay. So, respiratory acidosis, we know, is when the CO2 is greater than 45 and the pH is less than 7.5. So this means that we have inadequate alveolar ventilation and we need to increase our minute ventilation to correct it. So we are going to need to increase our tidal volume or our respiratory rate to fix that. Respiratory alkalemia is when our CO2 is less than 35, our pH is greater than 7.45, which indicates our alveolar ventilation is too high and we need to decrease our minute ventilation to correct it. So this is commonly happens either because we either have our vent settings set too high, we start off and we have too high of a rate set or too big of a tidal volume set, and we're causing the alkalemia with what we've set. If the patient has pain or anxiety, that's going to increase their respiratory rate and can cause hyperventilation. Also, the other big cause is hypoxemia. So if my patient is hypoxic, they're going to naturally breathe faster, which is going to cause that alkalemia. So sometimes you need to fix the underlying cause to correct the alkalemia. It's really important to just always remember that any changes in the acid-base status impact electrolyte balance. So it's also going to impact things like that oxygen hemoglobin dissociation curve, which affects how the unloading or loading of oxygen on the hemoglobin and that oxygen transportation. So we do want to make sure that our patients in, acid-base balanced. We're always shooting to normalize pH rather than normalize CO2 in mechanical ventilation. Okay. Your mechanical ventilators have the ability to affect oxygenation. And we talked about PEEP and inspired oxygen with improving oxygenation in class. So our ventilators are set up to deliver a inspired oxygen concentration, or an FiO2. So by increasing our FiO2, that's going to help increase our P big AO2. That's the stuff that's actually in the alveoli. So if I increase my FiO2, that increases how much is actually in the alveoli. And then if I don't have a diffusion defect, then that is going to increase as the stuff that's in the alveoli increases. The stuff that gets into the heart capillaries also increases. So if I increase this, as long as there's no diffusion defect, this should also increase. Okay. But, inspired oxygen does have some limitations. We can go from 21% up to 100%. Usually this is going to work to improve our patient's oxygen if hypoxemia is due to like a ventilation perfusion VQ mismatch. But if it's caused by that diffusion defect or a shunt, then you're going to need something like PEEP to help fix that. If you have hypoventilation induced hypoxemia, meaning that like our patient scenario, I think it was last week in lab where we had, or maybe it was the week before, where we had that hypercapnic respiratory failure where our CO2 is really high. So let me just give you an example of what an ABG, or reminder of what an ABG looks like with this. So hypoventilation induced hypoxemia. This is where you have a pH, let's say it's 7.28, and a PaCO2 of, say, 76. And we're going to give you a normal bicarb, 23, and then a PaO2, let's say 56, okay? This is an example of a hypoventilation-induced hypoxemia, meaning my patient's alveolar ventilation is really low. Those patients probably got that rapid shallow breathing. So its tidal volume's not getting down for gas exchange, and because there's not a good volume of new air coming down for gas exchange, CO2 is not getting eliminated, but also O2 is not getting deposited. So that's an example of hypoventilation-induced hypoxemia. Okay. So your book talks again about your how to calculate out your PaO2. So increasing the FiO2 increases your PaO2 predictably. So if I increase my FiO2, my PaO2 should also increase, and then that's your um, oh God, what is this called again? Your oxygen alveolar tension equation here. And then you're going, so you can take this. Oh my God, sorry, my brain's not working. Okay, so this is your alveolar oxygen tension equation. Thank you. So you can plug the values into this equation and predict what your PaO2 would increase to be at any given FiO2. Okay, so we've done this equation in the past multiple times, that P big AO2 equation. Okay. So your book also talks about sh diffusion, right? So only so much of that, how much gets into that alveoli versus how much gets into the arteries or capillaries is going to be dependent on diffusion of the gases. So let's draw this out. Okay, so this is talking about, that equation from the other page talks about what actually gets into the alveoli based on FiO2. Fick's law talks about what gets across that AC membrane and into the capillary blood. Comes out of the heart as PaO2. Okay, so the things that are going to affect that are diffusion defects. So your A is your surface area. So how much surface area there is, how many alveoli are open and ventilated is your surface area. Your D, your diffusion coefficient, doesn't matter because we're talking about the same gases always, right? Oxygen and nitrogen and things like that, and air. Your P1 to P2 is your pressure gradient, okay? So this is your how much pressure gradient there is there. So this is your pressure 1 is the pressure in the alveoli, and your pressure 2 is the pressure in the capillaries. Okay. Your T then is the thickness of this wall. So, by improving, I can improve my pressure gradient and improve diffusion by increasing my FiO2. That's going to increase my P big AO2. I can improve my diffusion coefficient by adding PEEP to increase the surface area, okay? Because PEEP is going to increase the amount of alveoli that are open. Okay, so this is another fun reminder. These are your carrying contents. So once the oxygen gets into the blood, so now it's in the blood, whatever got actually into the blood as PaO2, how much of it gets, this equation talks about how much of it gets actually delivered to the tissues, which is going to be mostly dependent on the amount of hemoglobin my patient has and how much of that is saturated with oxygen. Okay, so that is, those are going to be the most important effects, is the amount of hemoglobin and the amount that's saturated with oxygen. And again, we did this in CP Phys. That is what's going to affect how much is delivered to the tissues, more so even than my PaO2. Oops. Okay. So why does this matter? This is matters because the amount of alveoli that are open and stabilized is what's going to increase that surface area for gas exchange and help you improve that oxygenation. So there is kind of a sweet spot with our PEEP though. So we don't want to have so much PEEP. We want our PEEP to keep this open, but if we use too much PEEP, that's going to over descend or over ventilate that alveoli and squish this little capillary that it's resting, these capillaries that it's going to rest up against. So in that case, I'll have ventilation, but no perfusion. Finally, the only other calculation that we talked about is that increased tissue delivery. So when we're using mechanical ventilation, we can improve that arterial oxygen by increasing that FiO2 or PEEP, which is going to cause your carrying capacity or your CaO2 to increase. However, your tissue, what actually gets delivered to the tissues, is also going to be dependent on your cardiac output. So mechanical ventilation does have some negative effects on cardiac output. Because again, I'm adding pressure here. I'm adding pressure inside. This is his chest. Sorry, oh my God, drawing on a computer is awful. But this is his chest, and your heart has to sit inside your chest. If I add a lot of positive pressure all around the heart by putting your patient on ventilation, that decreases my venous return, which then can in turn, decrease my cardiac output. Okay, so simply by putting my patient on a mechanical ventilator, I am having a negative impact on their tissue oxygen delivery, and that's why, because of my effects on cardiac output, so I might need to increase my amount of carrying capacity of oxygen to help balance that out. All right. So the next section kind of talks about different types of settings that are on the mechanical ventilator. Feel like I'm gonna pause here and pick this up in the next actual lecture, just because some of that stuff might have been a lot. So we've already been lecturing for 40 minutes. I'm gonna stop with this section and then move on in part 2 with the effects of positive pressure on lung mechanics.